First thing I want to do is really thank Dr. Sharma for facilitating this whole presentation this morning. She went out and found the talent for us, and we have some excellent talent to speak to neuroendocrine tumor patients this morning. And the order of things, Dr. Sharma will cover in a few minutes, and we'll have a question and answer period at the very end of the presentations, and Paul Godaleski will be monitoring questions that will be submitted via the chat, and we'll move to having the question and answers after every presentation again. So Josh, have you got enough time?
No, not yet. Give me another minute or two and I'll be going. One sec.
Okay.
Although I do see that we're recording. You're good to go.
Okay. So let me turn it over to Dr. Sharma, and she'll be introducing our guests this morning, guest speakers. Take it away, Nance. You're on mute, Nancy.
Oh. Can you hear me?
Okay. Yep.
All right. Well, thank you so much, Gary, for inviting us for presenting for the Pacific Northwest Support Group, and also I want to thank Troy Onda from the Swedish side for making this happen. I want to thank all my colleagues, Dr. Ong, Dr. Itagaki, and Dr. Mehta for taking time out of their busy schedules to come and talk to our patients here. It means a lot to our support group to have good conversations with the providers. So thank you very much, all of you. Dr. Ong, Dr. Itagaki, and Dr. Mehta are pretty well known in the area in their specialization fields. Dr. Ong is a very seasoned surgeon who has been in the area for several years. I have sent him patients from different places. I've been in the area, from Everett, from Whidbey Island, you name it. And he has always been very communicative and has provided excellent care for our patients. So thank you, Dr. Ong. Dr. Ong will be talking about some cutting edge treatments for the treatment of the neuroendocrine tumors along with surgery. Dr. Itagaki is a very well experienced interventional radiologist. He and I have shared several patients with Y90 and other liver-directed therapies for different cancer types, and especially neuroendocrine tumors. And we have had great success, and Dr. Itagaki will be speaking to us today about the liver-directed treatments. Dr. Mehta, who will be joining us shortly, has been in Swedish for several years. He's a radiation oncologist, and he was the first person to start, one of the first person to start PRT in the area, and he will be sharing his insights with us for PRT. So we can start, I guess, I can start with my presentation, and then Dr. Mehta can join in. And our plan was to keep the question and answer sessions at the end. These will be 10 to 15 minute presentations. So people can write their questions in the chat box, and then in the end, we will go through those. So I'm gonna go share my screen here. I hope I'll be able to. Can you see my screen?
Perfectly.
Okay. All right, so I will be speaking about giving you a brief overview of the neuroendocrine neoplasms, but also we will primarily focus on the systemic and the upcoming treatments of the neuroendocrine tumors. It's not moving, let me see.
In the left-hand corner of your slide deck, you can either use page up, page down, or you can see on the left-hand corner bottom, there's some arrows that go right or left.
Yeah, it's not, maybe did I share the slideshow? Yeah. Just go back. There. I think I picked up the wrong image. So sorry about that. So this slide just talks about the net classification by their anatomic site. The neuroendocrine tumors can arise in different organs of the body. So it kind of delineates, the foregut, midgut, and the hindgut. As we know, it's important to know where the origin of the tumor is in the treatment of the neuroendocrine tumors. This slide briefly talks about the histology, grade, and differentiation are two very important points which we need to take care of in neuroendocrine tumors. The treatments largely depend upon what grade tumor you're in. Interestingly, the net grade 3 can also be well differentiated. So not all grade 3 are poorly differentiated, but all poorly differentiated neuroendocrine tumors are grade 3. So this is something we have learned over the years. The incidence of the neuroendocrine tumors is increasing, of course, largely because of early detection and better imaging modalities. So the neuroendocrine neoplasms, you can see, are the second most prevalent tumor, second to colon cancer in the GI tumor world. So that's why a lot of GI oncologists specialize in these tumors. As we know, neuroendocrine tumors are related with the carcinoid syndrome, and these include flushing, secretory diarrhea, the wheezing, dyspnea, valvular lesions. We do now know that serotonin plays an important role in these tumors. So measurement of 5-HIAA is critical in the diagnosis of carcinoid syndrome and neuroendocrine tumors. There are some functioning pancreatic nets which also secrete other markers such as insulinoma, gastrinomas, which also your neuroendocrinologist, oncologist should be checking when you first present with the carcinoid syndrome. For non-functioning neuroendocrine tumors, chromogranin A, pancreastatin, and neuron-specific NLAs have been used. It is important to note that it may take sometimes up to 2 weeks for these tumor marker results to come back, and it also depends upon the laboratory you send these to. So it's important to know where which are these laboratories, so we have the accurate results. Again, the chromogranin A is affected by a lot of things in the body, what you eat and what medication you take, such as NSAIDs. So those should be stopped prior to the test at least a few weeks so that we have an accurate result. So there are other upcoming tests which some of the patients might already know about. These are the NET test, which has been kind of coined in from Dr. Maudlin's team at Yale. And this is a multigenomic microRNA liquid biopsy test. Is supposed to be very sensitive and specific, at least in the clinical trial settings, and the research data suggests that. And so we are waiting on the NANETS guidelines on the utilization of this test, and hopefully would be helpful in prognosticating these tumors. There's another one that's coming, upcoming, the prograstin levels. Dr. Chauhan's team at Kentucky is doing some research on this. It's still investigational, but if approved, would prove to be a very sensitive test for the neuroendocrine world. The imaging modalities, we already know a lot about Octriscan, and now with the gallium-68 DOTA PET, the sensitivity of these of picking up these tumors has increased a lot. So you can see in this picture how an octreoside scan and the gallium scan of the same patient can be so different, and gallium scan has definitely helped us pick very early tumors early on. Copper-64 is a radionuclide that allows more time between manufacture and transfer to the sites of PET scan. The half-life of copper-64 is 12 hours versus about 70 minutes for the gallium-68. So there is a lot of excitement that we could use it in the outreach areas where it's not possible to use gallium-68 scan. So the treatment of neuroendocrine tumors is a multidisciplinary approach. During the subsequent talks, you will be hearing about the important key members of this multidisciplinary team at Swedish. I will be focusing on the systemic therapy options. So I will be touching on the somatostatin analogs, briefly talking about Prrt, but Dr. Mehta will be elaborating more on that. Targeted therapies, chemotherapy agents, and the more upcoming therapies, which are very exciting and hopefully will change the landscape of the neuroendocrine tumor. So somatostatin analogs emerged on the landscape for the treatment of neuroendocrine tumors in 2009. The first somatostatin analog to be approved for this indication was octreotide LAR. A clinical trial which brought the sandostatin LAR to the forefront of the NET treatment was PROMED study. This was a randomized double-blind placebo-controlled trial done on patients with well-differentiated mid-gut neuroendocrine tumors. So as you can see, the results, they demonstrated that progression-free survival in octreotide LAR arm was 14.3 months versus 6 months in the placebo arm. As a result, the octreotide LAR was approved as first-line treatment for unresectable and metastatic mid-gut neuroendocrine tumors. The second somatostatin analog to surface in the treatment of neuroendocrine tumor was lanreotide, which was approved after the results of the Clarinet trial. This was published in 2014 in NEJM. The trial included well-differentiated neuroendocrine tumors of the pancreas, midgut, and unknown primary. You can see that at the time of the publication, the median progression-free survival for the placebo arm was 18 months, but progression-free survival was not reached in the lanreotide arm. The trial does bring an important point that even in the absence of any treatment, the progression-free survival in the patients was 18 months. Therefore, patients with a limited disease burden, wait and watch approach can be utilized. Somatostatin analogs also improve symptoms in carcinoid syndrome. Another such drug which was approved was telotrestat ethyl or Zermelo. In this Telestar trial, which was a phase 3 trial, this was compared against a placebo in patients who had diarrhea due to the carcinoid syndrome from the neuroendocrine tumors. And a mean reduction of more than 2 bowel movements per day was observed in up to 33% patients treated with Zermelo versus 4% in placebo arm. And thus, this has been approved for diarrhea in carcinoid syndrome. Briefly about Prrt, which we'll be hearing much more later in the talks. Prrt was brought to the landscape by the NETTER-1 trial in 2017. So you can see very exciting results. It showed that the superiority of the lutetium-177 over sandostatin 60 the LAR 60 milligram in the control arm. At the time of this publication, the median progression-free survival was not reached for the lutetium arm, and now we know it is close to 30 to 35 months. Moving on to the targeted therapies, the mTOR inhibitors such as everolimus block growth, proliferation, and angiogenesis in the neuroendocrine tumors. The RADIANT-4 trial, which was published in 2016, showed superiority of everolimus over placebo in well-differentiated lung, pancreatic, and midgut neuroendocrine tumors. The progression-free survival was 11 months in the everolimus arm versus 3.9 months in the placebo arm. Another targeted therapy, tyrosine kinase inhibitor, sunitinib, was also tested in the pancreatic neuroendocrine tumors in this double-blind placebo-controlled trial, and we can see that sunitinib had a progression-free survival of 11.4 months versus 5 months in the placebo arm, and thus it was approved for the treatment for unresectable and locally advanced and metastatic neuroendocrine tumors of the pancreas. So moving on to the cytotoxic therapy, although chemotherapy has not been widely used in the well-differentiated neuroendocrine tumors, one combination that has been well studied now is the combination of temozolomide and capecitabine. As a result of the ECOG Akron Cancer Research Group E2211 results by Dr. Kunz in 2018, you can see that the combination has improved the progression-free survival to about 22 months. So this is a very promising drug combination in pancreatic neuroendocrine tumors. So just briefly about emerging treatments as well, I will put them into 3 categories: targeted therapies, combination treatments, and the immunotherapy. The recent international study in China and Europe tested surufatinib, which is a multi-kinase inhibitor, they first did the pancreatic, and this slide shows the extrapancreatic net tumor results, and you can see that there is improvement in progression-free survival compared to placebo, and thus hopefully we will be getting the FDA approval for this drug later this year. Another drug that has been tested and has shown good phase 2 trial data result is Camber Xentanim. Now we have an alliance trial, the cabinet trial, which is using this drug with versus the placebo after the NET patients have progression on everolimus, all advanced NET patients. So this would be a game changer too. After, if it's a positive study, we'll have another drug in our armamentarium to fight or delay the progression in neuroendocrine tumors. Other set of trials are looking treatments in combination with Prrt. An ongoing phase 2 trial in Australia is the Prrt with capecitabine and temozolomide. And the initial results were presented at the ASCO in 2020, and the progression-free survival was a little bit better in the combination arm. I'm sorry, pretty similar. It seems like it's a little better in the Prrt alone arm, but definitely we have the grade 3-4 toxicities more in the combination arm. So we'll have to still wait for the final results, but it seems like that combination of chemotherapy and Prrt is not very effective. Other targeted drugs that are being used with Prrt and are in the phase 1 trials across America are Tripene, which Dr. Chauhan's team is testing with Prrt. It's a radiation sensitizing agent, and the hope is that this will help improve the efficacy of PRRT. Olaparib, which is a PARP inhibitor, causes DNA destabilization after these cells are exposed to PRRT, and the hope is that this will also improve the efficacy of PRRT. We do have in the Providence system a trial open with Camber Xentanim that Dr. Koenneke is leading, and hopefully it should be available once it moves on to the phase 2 across different sites in Providence and other places in USA. Immunotherapy has not shown much promise in the neuroendocrine tumor world. The PD-L1 inhibitors haven't shown much success, unlike other tumor kinds. However, the bispecific antibodies are being tested, and the phase 1 data from the DUET-1 study of this XMAB tidatumab, which is a humanized anti-somatostatin and anti-CD3 bispecific antibody, and it is showing response rates of 43% across dose levels and a good safety data profile. So this is a exciting drug which we should keep an eye on and see if this also comes into the different targets that we can use for countering the neuroendocrine tumors. So sequencing of therapies is very important. It's the key, sequencing of the therapies you can see in different midgut, pancreatic, and lung nets is important to kind of get the maximum benefit from each chemotherapy. In combination with the liver-directed treatments to maximize the benefit of the currently available therapies for neuroendocrine tumors. This again stresses the multidisciplinary team approach that we need to make made available for these patients. And at Swedish Cancer Institute, we make this a priority for our patients, and we also work closely with our network providers throughout the region so that patients can get good quality care closer to home. So that's all I have. Thank you so much. And we can go ahead if Dr. Stop sharing. Is Dr. Mehta here? Yeah, Dr. Mehta is here. And
yes, Nancy, thank you.
Thank you, Dr. Mehta.
Let's see if I can there we go. Do it.
Dr. Mehta, you should be able to share your screen as well.
Perfect. Oops. Can you see me?
Yes.
Oh, wonderful. Wonderful. Well, thank you, Dr. Sharma, for putting this together. This is an exciting time to talk to everybody about some of the things that we're doing. I have a small part of this presentation, and it's to talk about PRRT. And I'd like to sort of build on what Dr. Sharma has already told us. And it's as a starting point, I would say that radiation has been used for a long time to treat cancer. There are records dating back more than 100 years of using radiation to treat cancer. And if you look at all of the patients that we see today, about half of them receive radiation at some point during their treatment. Historically, when we talk about using radiation to treat cancer patients, we're talking about somehow aiming that radiation from outside their body to treat tumors somewhere inside the body. So the history in radiation has been, how do you get that radiation inside the body? And they have worked to advance and modernize and implement new technologies to get linear accelerators to deliver photons, which are a form of X-rays, protons, which you might have heard about, carbon ion and helium particles are on the horizon. There are planning improvements that have allowed us to target better, so we can target in 3D, account for motion, which is 4D, use image-guided techniques or intensity-modulated techniques, and more recently deliver very, very high doses of radiation with absolute precision to small areas or small targets in the body. So there's been a tremendous focus on trying to get the radiation exactly where we want it and try to miss the normal tissues around that. At the same time, in the world of radiation, there has been an evolution in the world of radiopharmaceuticals. So back in the 1940s, we started using radioactive iodine as a treatment for thyroid cancer. More recently, we've been using radium-223 as a medicine to treat metastatic prostate cancer. In that particular case, the radium is attached and made to look like a calcium molecule. Since calcium molecules get incorporated into the bone, this is a way of destroying prostate cancer that has gotten into the bone. There have also been a variety of treatments using radiation attached to antibodies. The perhaps most successful of these have been used in the treatment of lymphomas, where they attach to a CD20 molecule, for example. So the idea behind any of these sort of radiopharmaceuticals is that you take a radioactive compound, you somehow link it to a molecule that targets, and that the cancer should have some sort of receptor on its surface that you can then send the target in linked to the radioactive compound. And if you're successful, then you're delivering the radioactive payload, if you will, right to the cell, right to the target. And you're avoiding the whole idea of coming in from outside the body to treat inside the body. Lutathera is actually one of those molecules. They have attached a radioactive particle, in this case it's 177 lutetium, to a linker molecule to octreotate. Okay, and this is sort of the chemical makeup of that. But in a more cartoon action, when you infuse this agent into the blood system, it circulates in the blood. It concentrates because it has that target, and the receptor of these neuroendocrine tumors have that receptor. Lutathera then binds to these receptors that are overexpressed by these tumors. It is brought into the cell, and the radiation is delivered inside the cell, killing the DNA of that particular cancer cell. And that's what leads to the cell death. So you're actually getting the radiation right where you want it. And the radiation doesn't have to penetrate so deep. So at least theoretically, you're delivering it locally at the cell level, and you should have fewer side effects. So this has been studied in GI carcinoid tumors or GI net tumors. And this really gives you a sense of the target sites that we have been looking at in sort of a cartoon form, okay? And this is the largest study to date that has been done looking at this, and Dr. Sharma had alluded to it. This is called the NETTER-1 study. Basically, what it did is it took patients that had mid-gut neuroendocrine tumors, and these are all patients that had progressed on their octreotide or agents, and they were randomized to basically a high-dose, long-acting octreotide, or to receive the octreotide in combination with Lutathera, which is the radiation-labeled octreotide that we talked about before. There were roughly the same number of patients in each side of this trial. And remember, in these randomized trials, it's very important that the patient doesn't control which treatment they get, and the doctor doesn't control which treatment they get. And that allows for balance. So you get randomly allocated to one of these two treatment approaches. So these included patients that had mid-gut neuroendocrine tumors. These were patients that had metastasized or progressed locally. These were patients that were inoperable, and they had already progressed during the long-acting octreotide. They had to be in relatively good shape. They had to have somatostatin receptors, okay? And they had not had any prior radiation that was significant to a large part of the bone marrow, and they had not had prior PRRT that were included in this trial. There were some laboratory values that had to be met as well, and if the organ systems didn't look healthy, they were not included in this trial. So it's a relatively healthy group of people that were progressing with this particular tumor type. The first thing that was noted was that patients that had gotten treated with Lutathera had a much better response rate, almost a threefold increase in response rate if you look at these figures, 13% versus 4%. I caution everybody that response rates, while very popular, and you see them in oncology studies all the time, are not really the end goal. We are not interested in having scans that show things that shrink, but actually we want people to have a higher quality of life and we want them to live longer. What was very impressive in this particular trial was the progression-free survival. When this was published, you can see that there was a significant, at least almost 80% change in progression-free survival between the patients that got Lutathera and the patients that were continued on octreotide. So once you start to progress on octreotide, there is a steady decline in outcomes for these patients with the disease continuing to progress. And it seems that there are a group of patients that can be treated with Lutathera where you can halt that progression and keep people alive for a longer period of time. This was really exciting because we hadn't seen these kind of results before in the treatment of this disease. If you look at overall survival, which is perhaps even more important, you can also see that the curves are different. The patients that got treated with Lutathera, and this is from the interim analysis, show that median overall survival still has not been reached, okay? And so there is an improvement in survival, and I think that is more important than looking at radiographic scans or any of the other assessments. We are potentially curing more people with this treatment. Now, the other side to that coin, whenever you think about doing a treatment, is thinking about what are the side effects that are associated with this treatment. And it's very interesting. This is sort of a busy table, but it talks about the different side effects that we're seeing between patients that were treated with Lutathera versus the long-acting octreotide. And generally speaking, and compared to many studies, this was considered a very well-tolerated treatment. And so most of the patients that we treat seem to do pretty well. Another question that comes up when you consider a new treatment is how many of the patients that were randomized to receive the treatment actually received the treatment. And you can see that, you know, more than 85% of the patients that were randomized to receive the Lutathera actually got the prescribed dose. There was a dose reduction in about 6% of the patients that had been randomized to receive it. So generally well tolerated. Most people who get the treatment are able to complete the treatment. It's not so toxic that only the surprising few can actually benefit from the treatment. So I think that's exciting to see a treatment that actually works and that is relatively well tolerated. If you think about sort of the most common sort of grade 3 and 4 toxicities, those are the sort of serious things that happen. You can see serious, because whenever you have side effects that can be any degree on the spectrum from mild to severe, but the incidence of very severe side effects are fairly low, okay? I want to spend a few minutes talking about this treatment because in some ways it's a relatively unique treatment. We have been doing this treatment at the Swedish Cancer Institute for a few years now, so we've gotten good at doing it. But the first time around, I would say that it's particularly unique. Patients will come in and they will have 2 IV placed, one in each arm. In the first arm, the IV is used to deliver fluids, and the fluids have amino acids. And the purposes of the fluids and the amino acids are basically to make sure that the patient stays hydrated and that the kidneys are protected. because when you do the infusion of radioactivity, you're going to flush out any excess dose through the kidneys. And so we want the kidneys as protected as possible. And we do that by loading the patients up with amino acids and IV fluids. After they've had the amino acids and IV fluids, and we typically also give everybody an anti-nausea medicine sort of just prophylactically, just in case. So that process might take about 30 minutes to an hour. We would meet the patient and bring the radioactive material in. And then using the other IV in the other arm, the radioactivity would be infused. The radioactivity is actually infused through a cascading effect. You have the radioactivity in a small vial. You have a needle and an IV going into the patient. You have a needle coming from an IV bag that is dripping fluid into that vial and pushing the radioactive fluid into the patient. So it's a little bit of a cascade of water, if you will, that is then dripping slowly into the patient. That slow drip over the course of 30 minutes infuses the patient with radioactivity. It takes us another 5 or 10 or 15 minutes to flush the lines, disconnect everything, and then the patients would actually stay for another 4 hours of IV fluids with amino acids. So the whole process takes a little bit more than a half day to get this treatment. The treatment is given a total of 4 times. It is given sort of on day 1. After the Lutathera is given, we generally treat with a dose of octreotide. 8 weeks later, and then 8 weeks later, you get the second Lutathera in 16 weeks, and then 24, and then 24 weeks. So it's basically every 8 weeks, you would get a total of 4 doses of Lutathera. In between those Lutathera doses, you would have a 30-day octreotide dose. The octreotide dose can be administered closer to home if it's more convenient, as we have patients coming from a number of different areas for this 1 day or half-day treatment, if you will, for the actual Lutathera. We talked to the patients about the safety precautions for this particular treatment. And we have a full list of precautions that we tell people. Obviously, patients shouldn't be breastfeeding, proper contraception should be used. But I think the big things that people find as different from day-to-day life are, we typically ask them to use their own toilet for a period of time. We ask them to sleep privately, keep their distance from very young children or pets that are very close to them for a certain number of days. But for most patients, they don't seem to find this to be particularly draconian and seem to follow these instructions quite well. I will tell you that we monitor these treatments, the rooms, the staff, the personnel that are giving these treatments, and we monitor it through a series of radiation badges and radiation measurements. And to date, the physicist and the physician who administer these treatments, even though they're in very close proximity to the highest dose of radiation when it's being administered, basically don't have any dose. So this is basically further a testament that when you can infuse it and it goes into the patient's body, the dose is delivered from the inside out, and there's very, very little exposure to anyone else. It's an exciting time for Lutathera. It's an exciting time for patients who are getting this treatment. But people are always looking to try to improve it and see if they can do better. You heard briefly about some of the different trials that Dr. Sharma was talking about. I think Lutathera plus the triompine is very interesting. It is trying to use a drug that exploits or handicaps the body's ability to repair from DNA damage. And as the Lutathera damages that DNA, you're using something that keeps the body from repairing it or keeps the cancer cells from repairing it. So it's quite possible that we'll see some sensitization and some improved efficacy. They're also studying Lutathera in more advanced forms of NETs. They are combining liver-directed therapy and immunotherapy with Lutathera. We are looking at Lutathera immediately before surgery or after surgery when we're trying to do combination approaches. And interestingly, right now, while we deliver the Lutathera directly into the blood, there is work looking at directly delivering the Lutathera closer to where the targets are. And there are some targets that lend itself to more direct delivery, like direct hepatic infusion, for example. All of these are being sort of studied in future trials. Lutathera is also being looked at in other cancer types. So bronchial neuroendocrine tumors are being studied. There's some data looking at it in meningiomas and recurrent breast cancer. There's also some data looking at Lutathera in pheochromocytoma and paragangliomas that are in clinical trials today. So we may see this expand its applications in the future. If you think about radiopharmaceutical space overall, of which Lutathera falls into, that whole space is growing. There is definitely work going on in other disease types like melanoma, lung cancer, colorectal cancer, and leukemia. There are new radiopharmaceuticals being re-engineered from existing compounds, particularly those compounds that are used to image cancer. So if you can detect the cancer on an imaging study, it follows that you can then link that same target to a radiation. PSMA is perhaps the most promising of that target for that. And of course, within the space of radiopharmaceuticals, there are other radioactive agents that are being looked at linking to these various targets to see if there could be some improved efficacy. The idea of combining radiopharmaceuticals is very interesting. You know, the space of immunotherapy is perhaps the most exciting space in oncology in general, at least in the current times. And there is an interest in why some patients that get immunotherapy respond so well, and other patients that get immunotherapy don't respond very well. And the thought process is that the immunotherapy works in patients where the body can recognize the cancer. And so there's a description of some tumors or some cancers being cold, i.e. not recognizable, and some cancers being hot, being recognizable. So the idea is that if you use radiopharmaceuticals, you can convert these tumors into hot tumors, meaning that you kill the cells, the body's exposed to the material inside and outside of the cell in a different way, and suddenly the immune system is revved up. And so combining a radiopharmaceutical and an immunotherapy agent makes a lot of sense, because you could potentially get a greater immune response if these are done together. The idea of radiopharmaceuticals and radiation sensitizers makes sense as well. We have used radiation sensitizers with external beam radiotherapy for some time. And so it follows that anything that could further accentuate the damage caused by radiopharmaceuticals could create synergy. And then, of course, combining radiopharmaceuticals with some form of external beam radiation is another potential idea or strategy to get a higher dose and more debulking of these tumors. So I wanted to sort of kind of give you a background and a sense of this particular emerging area and where it fits into the world of radiation, as well as into the treatment of these tumors. And I can hand this back to Dr. Sharma.
Thank you, Dr. Mehta. Our next presenter is Dr. Evan Ong, who will be talking about the electroporation as alternative to surgery in pancreatic neuroendocrine tumors.
Yes, hello. Can everyone hear me?
Yes.
Okay. Thank you very much, Dr. Sharma, for the nice introduction. I really appreciate it, and I appreciate the opportunity to talk, speaking to you about some of the things that we're doing in the surgical realm. I'm going to share my screen in just a second here. All right. So I have the a unique ability to talk about some of the things that concerning what we do for pancreatic neuroendocrine tumors in the surgical realm. It's a little bit different from a lot of the other therapies that we do out there for pancreatic neuroendocrine tumors. Surgery is one of those things that we don't test, meaning there's not a lot of randomized controlled trials concerning surgery. We do understand that surgery is an effective mode of treating patients with any kind of neuroendocrine tumor. And in a way, I'd like to say that for patients that have localized disease, it is the gold standard. So to begin the talk, I have no disclosures. I have no relationship with the device that I use here. The device, which is called the Nanoknife, utilizes irreversible electroporation, and it is FDA approved. It is not an experimental device. So speaking about current surgical treatment options, and I'm going to speak really as a hepatobiliary surgeon, when we talk about pancreatic and neuroendocrine tumors, my specific realm really lies within the disease and its involvement within the liver and the pancreas. And if you look at these spaces, surgical resection is pretty obvious. This is the idea where you're performing a technique that excises the lesion that is meant to be removed. Ablation differs from surgical resection because you are not excising the lesion. You are actually using some mode, whether thermal or non-thermal, that is used to destroy the lesion in place. And if you compare the liver versus the pancreatic spaces, ablation doesn't really lie as a potential treatment option in the pancreas in the typical form. When we do ablative techniques within the liver, typically they're thermal. So the idea here is you're using some form of device that generates heat to essentially necrose the tumor. And the idea here is that the advantage of doing ablation is that you are preserving organ function. Usually these are less invasive techniques. Recovery for the patient is advantageous. Patients recover from these procedures much faster than the typical surgical resection. Within the pancreas, ablation has been performed and has been reported upon. Unfortunately, because of the nature of the organ, one of the biggest side effects from ablation is ductal injury. Unfortunately, there is a high risk for pancreatic ductal leak, which leads to infection, and the patients have not a shortened recovery, but a very prolonged recovery. And because of this, thermal ablation has really been frowned upon within the pancreatic treatment. So in the last decade, there's been a very interest in this utilization of electroporation. So what is electroporation? So electroporation is a technique in which the cell, at the cellular level, the cell membrane is essentially disrupted. And this is actually used in a lot of laboratory techniques to essentially allow for a permeability of the cell to allow entry of either a drug or DNA within the cell. And there are different types of electroporation. Electroporation obviously uses electricity, but there is permeabilization that's been used with soaps and certain drugs that allow for the same type of treatment. Obviously, the idea here is that you're using electricity to create small porous holes that allow for either drugs or DNA to enter the cell. And so understanding this conceptual idea at the microscopic level helps you to understand how this is going to be utilized within the pancreas. So one of the side effects that they saw using electroporation within the cells or within the tissue specifically is that you would have destruction of cells when you did irreversible electroporation. So there is a reversible zone where you're using a voltage that allows the cell membrane to reconstitute. But when you do irreversible electroporation, essentially you're making such large holes into the cell itself will not survive the poration technique. But what's interesting is that structures like the arteries and nerves, these things are not affected by the technique because they're essentially acellular. And so one of the problems with ablation within the pancreas was that it would cause destruction of tubes and vessels, leading to bleeding and pancreatic leak because of disruption of the duct. And so one would presume that by doing this technique, one could preserve some of the function of the pancreas and avoid those injuries that occur. So irreversible electroporation is the technique, but the device itself is called the Nanoknife. Obviously not chosen by myself. This is what the device looks like. You can see the generator in the right side of the screen. These are very small catheters, and essentially the catheters are housed in such a way that the tip has to be exposed to allow for the electricity to generate between the two probes. And this is one of the devices. In which there is no grounding pad, which is seen typically in thermal ablation, such as radiofrequency ablation, where the electricity has to create a current between a grounding pad and the device. In this type of device, the current is only generated between the tines between these catheters that are inserted. So the Nanoknife is essentially the application of irreversible electroporation into the soft tissue. And the idea here is that you're using high voltage electricity to generate these porations, these cells to be disrupted at the cellular membrane. But the idea here is that by using high voltage but low energy direct current, you do not rely on thermal ablation. So the idea here is you're avoiding the injury to the surrounding tissues, but you're at the microscopic level, you are creating the injuries to the cellular membrane that the cells won't survive. So again, the idea here is that the utilization is to avoid the use of thermal ablation. We are not trying to create a replacement for a radiofrequency ablation or microwave ablation, which are devices that use heat to destroy tissue. And then it can be used in combination with radiation therapy, but it has a kind of the same complement, meaning external radiation. The idea here is that you're treating an area, and so it's regional in terms of its treatment. And the concept also is that, that you can treat the location, when I say here, with a more durable treatment. The idea here is that you can repeat the treatment a second, a third, a fourth time, as long as you're able to insert these catheters. This device is not solely just in the hands of the surgeon, but can be used by interventional radiologists. And where it's been used is in two forms. It's been more heavily used in the setting of pancreatic cancer. Obviously, when we talk about patients with pancreatic cancer, or in patients that are going to receive any kind of surgical treatment, one of the issues has always been about being able to remove the disease safely. So in one setting, patients that have locally advanced pancreatic tumors, when they have vascular involvement, this may not allow for or be a relative contraindication to performing the surgery. By utilizing the irreversible electroporation or the Nanoknife, the idea here is that you're able to essentially try to reduce the risk for local recurrence at the site by pre-treating the site of the resection margin. So, on this picture, essentially against the vessels where you have the lesion touching up against these vessels, these probes are inserted prior to the resection. The area is treated, and then you go forward with the resection. The other technique that's been used is what we call in situ ablation. So again, this is more like the ablative technique. So instead of enhancing the resection, the idea here is that we know a patient that has encasement or involvement of the vessels that makes surgical resection not an option. One of the, very similar to radiation, the idea here is that you're placing probes to encircle the disease and you're treating that disease locally. Again, the risk profile of this is not the same as radiation. Clearly, with external beam radiation, you're avoiding an incision. The placement of these catheters are typically done in an open fashion because of the location of the pancreas. Doing the in situ ablation is an adjunct to patients that have received chemotherapy for a long term, have not developed metastatic disease, and they may have already received radiation, but there's a limit to how much radiation they can want. Being able to treat these type of patients. This is the typical readout. Because it's high voltage, the patients have to be completely, the general anesthetic, so the patients are asleep for this procedure. But more importantly, these patients, when they receive the treatment, the voltage that's delivered has to be in sync with the cardiac rhythm. And the patients have to be totally paralyzed. Otherwise, the high voltage can defibrillate the heart. Patients can actually twitch because it's such high voltage. And you can see that what we're doing here at the bottom of the screen with these, when these pulses are done and they're done in sync with the heart, what we want to see is a relative change of about 10 to 12 amps in terms of current. So the idea here is that you're creating perforation in the cells, and because you're causing perforation, the current can actually travel through these cells. And so you're seeing an increase in current as a way to demonstrate that you've actually effectively treated the site. So this is a paper that kind of describes it, what the accepted change in the amplitude of the current. And what we mean by change in the amplitude, meaning the starting amps and where we finish. It's not the actual deflection. There's been limited studies that have looked at the relationship of and the utilization of irreversible electroporation in locally advanced pancreatic cancer. I can tell you there have not been any studies, large registry trials that have looked at IRE and the utilization of neuroendocrine tumors. I think that's something that is unique to myself. You'll see, I'm going to present a little video. We've been doing irreversible electroporation since 2010. And I have a video from the 2013 or 14 where we presented the utilization of it in the treatment of neuroendocrine tumors. But if you look at these, a lot of the studies have been done in the early 2010s, looking at the efficacy and safety, as well as some of the outcomes associated with it. And, this is the outcomes are, these are retrospective studies. So it's a little skewed, of course, because you are picking the best patients to do this, but it clearly demonstrates some advantage. These are patients that have stage 3 pancreatic cancer, and you demonstrate, and this is a multi-institutional study, and they demonstrated a pretty lengthy survival in patients that were considered unresectable, and with the only treatment options being chemotherapy and radiation. Fortunately, as such, for pancreatic cancer, the adenocarcinoma, the failure is usually metastatic. So it's not recurrent disease. That's a testament to the fact that we are able to treat things locally, but unfortunately the disease still progresses in a metastatic fashion. So in terms of irreversible electroporation and pancreatic neuroendocrine tumor, at our surgical meetings, when we discuss the utilization of irreversible electroporation, I've always thought that the Nanoknife was a great tool for patients with pancreatic neuroendocrine tumor. Partially the fact that the disease in itself typically has a very good biology and a very good prognosis. And in spite of metastatic disease, which is a contraindication of the utilization of the Nanoknife in patients with pancreatic adenocarcinoma, I believe that when patients that have metastatic disease, that this is potentially a great treatment tool to treat the primary site of disease. The vascularity of the neuroendocrine tumors allows for a much more distinct visibility within the ultrasonography. So you have to be a very good ultrasonographer when you're doing it intraoperatively. This is how we actually place the catheters, and these lesions are then well circumscribed and easy to treat, as opposed to patients with adenocarcinoma, which sometimes can be more effusive. Small lesions can be treated in situ, meaning that we can ablate this within the pancreas. So this is a new type of treatment to avoid a surgery. And then the idea here is that very commonly we do this in the distal pancreas. So you're avoiding the development of diabetes, you're avoiding pancreatic leak because you're not creating destruction of the duct. So, but I have to say that this is patient driven. I mean, the Nanoknife is not something that is well advertised, and it's not something that is well known. There's a huge role for patient selection. Patients that come see me are typically, they learn about the technique and then they want to know if this is something that they can apply to themselves. So this is something that's very common, that when patients are seen by the surgeon, it has to be either patient driven or surgeon driven. It's not typically driven by our medical radiation or radiation oncologist. So I was going to just present a fairly short video. This is actually was presented some time ago when I was at the University of Arizona. And I'm going to turn off the volume here, and I'll fast forward. Let's see. Are you guys able to see the screen, the video?
No, we aren't.
We aren't. Okay.
You might want to reshare your screen and hit it.
It says it's paused, so let me resume the share. Is that better?
No.
You can see now, right?
So change the share, reshare your screen, and share the actual video. Go to advanced. Instead of basic, go to advanced, and then select that particular video that you're trying to do, and allow it to say that optimize for sound and video, and there you go.
Do you see it now?
Yes.
Okay, good. I'm glad I'm semi-useful in terms of the technology. Okay, let me see if I can. All right. I'll speak to it. So this is actually a presentation from 2013 to the American College of Surgeons. This is actually a patient that received irreversible electroporation prior to this procedure. He's 80 years old. He had an elevated chromogranin A at the initial irreversible electroporation. It was done laparoscopically. He has a history of AFib. He was actually had a pacemaker. And essentially, he had his IRE, and unfortunately, he developed a recurrence with a recurrent mass seen on surveillance CT examination. So what was offered to him was to perform a robotic approach. Part of the reason was that we were worried about the changes that may occur in the lesser sac. This is a CT scan that demonstrates the location of the recurrence next to the site of the ablation. The ablation is actually slightly lateral to it. So we offered him a robotic assisted laparoscopic pancreatic resection with irreversible electroporation for margin accentuation. We used the previous port sites. This is just the sites that were necessary to be able to provide access. And then we'll fast forward here in a second to us using the robot to enter the lesser sac. So to give you an orientation, the top of the screen is toward the anterior abdominal wall. What's being held in the left hand is essentially the stomach. So you have the stomach, and what we're trying to do is enter the lesser sac after it's been previously treated and previously resected. And so the advantage of the robot is this kind of image that you can see, and we're taking down. Typically, this area is not scarred. And so the advantage is to be able to really provide exposure in a safe way. Then you're looking at the inferior border of the pancreas. What we're trying to do is free the entire inferior border of the pancreas from the retroperitoneal space. The left hand is grabbing very close to where the tumor is, and we're just taking down adhesions. And as you can see, when you use heat or electricity in a thermal way to destroy, it creates this. You can see the plume of smoke that you can see as we divide and use energy. to destroy tissue. And so that's very consistent. I highlight that because that's what you typically see when you perform any kind of thermal ablation. And so now you're seeing, that's actually what I've encircled there is the actually primary recurrent site. And then right lateral to it, you'll see that's the area of the previous ablation. Now, I have to say that this video, when it was presented, when we removed the place that we ablated first, that was actually the first pathological tissue demonstrating the true side effects after you perform an ablation. I mean, typically when you perform an ablation, you don't come back and you remove the site of the disease or that's been destroyed. So there never really was any pathological tissue to demonstrate actually what happens to a tissue that's actually ablated with irreversible electroporation. So this was part of the excitement to the procedure. But essentially, we just go along. What you're seeing here, this big device, this is actually an ultrasound. And unfortunately, I can't show you the ultrasound, but the idea here is you can see the ultrasound being being placed on the pancreas to be able to visualize the relationship of the duct to these lesions. And so again, you see the fibrosis is the previously treated site with the IRE, and the mass that's recurrent is just lateral. And that's one of the risks that occurs when you perform irreversible electroporation or any sort of ablation, as opposed to when you perform a resection and you can determine a margin. When you perform an ablative technique, that's the risk, is that you can potentially leave disease behind that allows for recurrent disease. But the advantage in ablation is that you can still go back, and as long as you can go back, you can still do it in a safe manner, and you can treat these patients. So what we'll do is I'm going to fast forward a little bit here. You'll see us remove the fibrotic area. This is a bag. This is how we extricate disease. We place it in a bag and we remove that from each port. Again, same thing here. What we've done, these are what I fast forward, but you can see this. This is the neuroendocrine tumors are very well vascularized, and you can see that there's a lot more cautery that's required to control bleeding, and this is essentially an enucleation of the disease. And so, when we enucleate, one of the risks, of course, is that we're taking the disease out. We're not taking out the entire pancreas. So you can, again, have recurrent disease, and that's the reason why we use the IRE to perform a margin accentuation. Again, what you can see here is us trying to control bleeding from this well-vascularized site. The previous dissection of the fibrosis itself was not vascular. That's why you don't see a lot of bleeding. And so then we go forward with doing the IRE, and you can see these are what the needles look like as they're being inserted. Typically, we'll insert them to bracket the lesion. There'll be 2 of them, and we're basically bracketing the margin of where the previous resection zone was. And then you'll see this is it being treated, and what you'll see is a pulse. I don't know if you can see but there's a pulse. And then when we remove them, there's actually no thermal ablation, and that's the reason why you get bleeding. So as opposed to regular ablation, there's usually a lot of, when you use heat, you get this plume of smoke. As you saw, the treatment really doesn't create this huge effect. So it's usually underwhelming. And at the beginning, when you actually do this technique, you're a little worried that actually it didn't really work because there really isn't this tissue change. And again, this is a testament to the fact that the safety profile isn't to destroy tissue, but it's meant to electroporate. So the patient did fairly well, was discharged post-op day 4. This is just, it was delayed because of the return of bowel function, but essentially demonstrated a well-differentiated neuroendocrine tumor. Specimen 1, which was the fibrosis, was a post-electroporation treatment zone. And so this is the fibrosis, one of the unique things is that the way the tissue is destroyed when the cells are porated, it creates basically a CD4 macrophage tumor cell, apoptotic death. And so the macrophages were an example of how, instead of creating that necrosis, it's the immune system coming back and destroying those cells or picking up those dead cells. So I want to thank you for the opportunity to present, and I know that there'll be questions later on, but I'll set this back to Dr. Sharma.
Thank you so much, Dr. Ong. A very exciting treatment, and I hope that we can use this more in conjunction with surgery or ablation or other techniques to help our neuroendocrine patients. Our next speaker is Dr. Itagaki, and he will be talking about liver-directed therapies.
Okay, hold on one second. Let me try and get my PowerPoint going here. Share screen. Advanced.
To do PowerPoint, just use the basic. There you go.
Can you see the
Beautifully.
PowerPoint? Okay. Thank you very much, Dr. Sharma, and all the attendees for allowing me to speak. I am an interventional radiologist, which is a specialist in minimally invasive image-guided procedures. And I'm going to talk specifically about what's called local regional therapy. For local regional just means targeted at the liver for neuroendocrine liver mets. And so interventional radiology occupies a very unique position in the whole spectrum of treatment. When tumors are very localized, so they're in one spot, they are usually treated with surgical resection. And if tumors are spread all over the body, they've metastasized, very diffuse, then usually it's systemic therapy like octreotide or Prrt, which we heard about earlier. And interventional radiology procedures occupy this ground in the middle where tumors have spread to the liver, but they've not really spread outside the liver. And that's where we can have an effect in terms of suppressing or even potentially curing their growth in the liver. So just a quick overview. I'm going to keep this a pretty short presentation, and I know we have a variety of people in the audience, so I apologize if I'll try to keep the medical lingo to a minimum. We'll talk about the role of IR in the treatment of liver mets, percutaneous ablation, which is a way of treating the mets by essentially burning them. Transarterial embolization, there's 3 different kinds, and then a little bit about perioperative and postoperative management. So percutaneous microwave ablation is a way in which we can treat, in a targeted fashion, we can treat tumors by, for lack of a better term, by burning them. And what this involves is putting a needle through the skin into the tumor, and the needle has a special tip that has a microwave transmitter on it, and it essentially cooks a localized zone around where the needle is placed. You can see in this picture, this is actually at a conference that I attended a couple years ago, and they brought beef livers, and we were able to see the visual effects of putting these needles into the beef livers, and you can see that in the area where the needle was placed, the tissue is actually cooked. And using a variety of settings, we can have very precise control over the diameter and the length of the ablation zone. And when a patient would come to us for a microwave ablation, would typically be somebody who is not a surgical candidate. So they have too many comorbidities. In other words, they may not be able to handle a surgery, or they have too many lesions in the kidney, or sorry, in the liver, where it cannot really be safely surgically resected. the tumor is in a position where it's not safe to surgically resect. Now we try our goal is going to be to cure or completely ablate the tumors that we're going after. When we do percutaneous ablation, it's usually a pretty good procedure in terms of morbidity, which means that most patients will they'll check into the hospital, will do the procedure, and they'll go home the same day. Occasionally we have patients that stay overnight just for some symptom management. They may have some pain or some nausea, but in general, the recovery is pretty fast. And so from that perspective, it's very similar to a biopsy. If anybody's had a percutaneous biopsy, percutaneous means through the skin. So we're not making an incision and opening up. We're actually just targeting directly through the skin. And all of this work is done through a needle poke. Now, there's been a very minimal amount of research directly comparing percutaneous ablation to surgical treatment, but one study shows that they're somewhat similar. There's, however, a great deal of research that shows the efficacy of surgery in general for treatment of METs when a patient is a surgical candidate, and so that's really the first-line therapy if we can get that person to a surgeon. Okay, hold on one second. Oops. Okay. Here's an example of what it looks like on ultrasound when we're doing a microwave ablation. This is the ultrasound picture. The ultrasound probe is on the patient's skin. And this white line is the needle, and the tumor is encircled by this dotted line. I actually did this procedure last week. This was for somebody who had breast cancer mets to the liver, but it's exactly the same thing for neuroendocrine mets. This is an example of our one of our microwave needles. It's a 17 gauge needle, which is just slightly bigger than the typical needles we use for a liver biopsy, which would be about 18 gauge. So it's not that big of a diameter needle. It's relatively fine. We position it right in the middle of the tumor. We know what settings need to be set to get a ablation zone of a certain diameter and a certain length, and we set that. And here's an example of before we turn the device on and after we turn it on. And you can see all of this white stuff and that all of the structures behind the tumor are clearly seen before, but then during the ablation, they kind of fade away. And the reason is because what's happening here is there's a formation of steam bubbles. So ultrasound cannot penetrate gas. And so when we're doing the ablation, you can actually see the formation of steam, and that lets us know that all of the tissue within that zone is essentially killed. Are you able to see my my mouse cursor, by the way?
Yes, we are.
Okay, good. Just wanted to make sure. All right. So what are the limits of microwave ablation? Well, first of all, it only works for one or a few lesions. If you have 20 lesions in the liver, we're not going to be able to do a microwave ablation. Also, it only works for lesions that are on the small side. So sometimes people have very large masses. 5 centimeters is the absolute upper limit of what we can realistically do. So if they're smaller than 5 centimeters, we can potentially go after them. And of course, it works for patients that are not surgical candidates, but it doesn't work for in a situation where you have lots and lots of liver metastases all over the place. And it doesn't work when the mets are very close to critical organs. For example, the intestines can sometimes be along the surface of the liver, and if there's a tumor right there, we don't want to accidentally injure or singe the intestines while we're trying to get the liver tumor that's close to the liver surface. So if another organ is in close proximity to our target, we may have to hold off on that. But the goal is curative in terms of at least these nodules in the liver. We're looking to completely eradicate them. Okay, now what happens when we have too many tumors to go after with ablation, or the size of the tumors is too big? Well, we still have some tools in our toolbox, and we can do what's called transarterial embolization. And what this is we take a small catheter and make a poke into the artery of the hip and navigate under X-ray the catheter into the tiny artery that goes into the liver. The catheter is about the diameter, for lack of a better term, it's about the size of angel hair pasta. So it's pretty small, and with X-ray we can navigate it very precisely. And when we get to the artery that is feeding the liver tumors, we inject particles, and the kind of particles we inject is what differentiates different types of embolization we're performing. But practically speaking, the technique is essentially identical. We park a catheter into an artery feeding the area of the liver that has the tumors, and we inject particles. So again, if we can do this with patients that have more diffuse liver disease, that are not candidates for surgery or percutaneous ablation, we can do it in patients who do and don't have carcinoid syndrome, and they could have limited disease or they could have very, very bulky disease. But it doesn't work if you have tumors outside the liver. Obviously, this is targeting the blood supply to the liver, and so if there are diffuse mets all throughout the body, then this isn't going to work for those. Then you're in the realm of systemic therapy. Also, we have to be a little careful in patients that have liver insufficiency, which means a limited liver function. So if a bilirubin is greater than about 2.0, then that means that you're starting to have liver failure, and we can't do this because that could just be a little bit too much of a shock to the liver. And so there's sort of three flavors of embolization, all very similar, but the particles we use are different. There's transarterial or regular embolization, we call it bland. And I don't really know why they use that term bland, because it implies a taste, but and we don't use taste descriptors for any of the other treatments, but that's how it's traditionally been called. And basically, this just involves infusion of not really microscopic, but nearly microscopic plastic particles, and they're biologically inert. They just flow into the arteries and they plug up the arteries. There's chemoembolization, transarterial chemoembolization, or TACE, which involves usually using an emulsion of oil with a chemotherapy agent, which is infused, and the little oil droplets plug up the tiny arteries and then start dispersing the chemotherapy agent directly into tumors. And then there's radioembolization with small particles that are impregnated with Yitrium 90, which is a radioactive compound that, similar to Prrt, emits radiation in a very localized fashion, but the radiation stays right there. It goes only about 2.5 millimeters away from where it was deposited. Now, in general, embolization works because tumors are, for lack of a better term, greedy. They recruit arteries to feed their own growth so that they suck up more blood and oxygen and nutrients than the normal liver tissue. And so that's why they show up on a contrast enhanced CT scan. And this is actually a characteristic that we use against the tumors in order to effectively treat them. We put the little catheter into the artery feeding tumors, and we inject these particles. And because the particles are floating in the blood, and because tumors suck up more of the blood to facilitate their own growth, they then preferentially suck up more of these particles. The normal liver, which has a relatively low metabolism, doesn't consume a lot of blood and nutrients, is thus relatively spared because it will pull in fewer of the particles. Okay, so the tumor's own biology is what allows us to preferentially deliver a more concentrated dose of these particles to it. And the particles are varying in size. So with regular bland embolization, or TAE, the particles are a little bit larger. And what they do is they then, as they travel with blood, they plug up larger arterioles. And the main effect of this is that they cause what's called ischemia or tumor ischemia. So they cut off the blood supply and the tumors die from lack of blood and lack of oxygen. With chemoembolization, the particles are a little bit smaller, and with radioembolization or tear, the particles are very small, and they go deep into the tumor before they get trapped in a small arterial, and they cause less ischemia, less deprivation of oxygen and nutrients, but they deliver their dose of radiation directly to the tumor. So blood is used to deliver the particles, but the mechanism of action is a little bit different. Okay, so here's an example of the particles that we inject with bland embolization. As I said previously, they induce tumor ischemia, which is a lack of nutrients and oxygen. And so after the treatments, it's not uncommon for people to have some pain in the liver, kind of like they got punched in the gut, because that's the sensation of those tumors dying off. And usually that's just temporary. It can last, well, some people don't have it at all, but it can last for 10 or 12 hours. And so my practice is I keep people in the hospital overnight just so that they can have IV pain medication. And most people are able to go home the next day with just an oral prescription. So the few hours after the treatment, when the tumors are actively dying from lack of blood, can be uncomfortable, but by the following morning, people are usually ready to go. Here's an example of chemoembolization. And what this is we make an emulsification of Lipiodol, which is a type of iodized oil. And it's basically an oil-water mixture. The medication, which in this case is red, this is doxorubicin in this case, is mixed in, and it's slurried up, and a emulsification is made. On a microscopic level, you see these little microscopic particles of oil, and then that's injected directly into the artery feeding the tumor. And the oil droplets wedge into the small arterioles, and then they diffuse the chemotherapy agent directly into the tumor. And one of the reasons why this is so effective is that when you get systemic chemotherapy, the chemotherapy is diluted throughout the whole body. So the whole body gets the same concentration of the therapeutic agent. And if the agent has some toxicity, you have to limit how much you get. You can't make the concentration too high because the whole body is exposed to it. When you administer the chemotherapy agent directly into the liver gets hit with a very high concentration of chemotherapeutic agent. A concentration high enough that, if it was given a whole body, it would probably be fatal. But it's deposited directly into the tumors at a very, very high concentration, but then the concentration that is then diluted in the whole body is actually quite low. It's subtherapeutic, so it's less than what is needed if you were giving it IV. So it allows us to essentially target very precisely with a high dose those liver tumors. And it's interesting because this iodized oil, Lipiodol, it's used in a very modern, highly advanced technique, but the oil itself is quite old. And this is just an aside. Here's an ad from 1933 in a radiology journal where they were doing chest X-rays, and they were dripping this iodized oil. It's poppy seed oil that has iodine impregnated on it, so it shows up in X-ray. And they were dripping it into people's lungs, and you can see that the directions say to anesthetize the pharynx or larynx with cocaine, and then the patient is wide awake, and you actually drip it into their airway and have them lean to the right or to the left, depending on which lung you want this stuff to go into. So it's kind of, I think it was an interesting thing to see that this is a very old medication, but also kind of like, how medicine used to be done. This is 90 years ago. And here, more recently, the same type of iodized oil This is in Papua New Guinea in the early 1980s. Patients had goiter, and what they would do is they would just get an injection into the muscle of this iodized oil, and the iodine would slowly be released, and it would treat the goiter. So this is before and after. When they're trying to treat goiter in these remote villages where they didn't have a lot of medical access. So interesting application of a very, very old medication using modern imaging and, impregnating it with modern chemotherapeutic agents generating a very good treatment. Okay, transarterial radioembolization with Yitrium 90 is the third flavor that we've got. And these are microscopic resin beads that are impregnated with Yitrium 90, which is a radioactive element. The beads are very small, so they don't cause a lot of ischemia. The radiation is emitted over a distance of about 2.5 millimeters. So when the particles wedge within the tumor, they will irradiate a zone about 2.5 millimeters around. There's some radiation gets out a little further, but usually very little is more than about 1 centimeter out. And so the radiation is very localized. So you're zapping the tumor and sparing the normal tissue around the tumor. This is a great treatment because it doesn't cause a lot of ischemia. There's not as much pain or nausea. And in fact, a lot of patients are asymptomatic after treatment and they go home on the same day. And the response is pretty good. Most patients don't get a complete response, but a majority will get some kind of partial response in terms of we can actually see the tumor shrinking considerably. It can also keep disease stable. So, in general, if there's a very high expectation that there'd be some type of disease control, either stable disease or partial or complete response. And this is for a one-day treatment where you come in, you have the procedure, and typically you'd go home the same day. So which is best? Is it the bland embolization? Is it the chemoembolization with the oil emulsion, or is it the radioembolization? Well, a recent study was published that looked at this, and really it's at this point not finding much of a difference at all. Odds of survival and progression-free survival are very similar. There is a kind of chemoembolization using drug-eluting beads, which I didn't really talk about in this talk very much, but it suggested not using that, that the oil-based chemoembolization was better. So it's a little bit of a wash. They're all equally effective. And my preference is the way that I do my practice is to typically do the Yitrium 90 first, if possible, just because the side effects in terms of how well patients feel the day of or the day after the treatment are better. The bland embolization can cause some pain and discomfort. Now, granted, patients still usually go home the next day, but I just feel like the radioembolization is a little bit easier. However, you have to be careful about doing that. Once you do it more than about twice to the same zone in the liver, you have to really be worried about or consider the total amount of radiation dose you're getting, because you don't want to cause damage to the normal liver tissue. Bland embolization, you can repeat many times, and you don't have to worry about radiation damage to the liver tissue with that. So here's just an example of one of the patients that I treated for neuroendocrine mets to the liver. This is a middle-aged woman, a really lovely lady who had, although we didn't know it at the time, it was a breast neuroendocrine tumor that had metastasized to the liver. And when she first came, her liver was huge. I mean, it was gigantic. You can see that the liver is actually down into the pelvis, and here's the hip bone. Here's the acetabulum where the hip is, and the tip of the liver is almost at the level of the hip joint. It went from the right to the left, all the way across the abdomen. The total estimated volume was about 5,500 cubic centimeters. So I treated her with Yitrium 90 tear to the right and left lobes. And this is what her liver looked like 10 months later. And I should mention that if you look at this before scan, it's actually the light parts of the liver are the normal liver. The dark parts are tumor. So you can see that most of the liver is tumor. And here's the after scan, and you can see that this part of the liver, the tip, has retracted all the way back up to the normal position, and the liver is now normal. Yeah, now there's still some little dark spots in here, so there's still some tumor left, but this was a striking response to Yitrium 90. I ended up treating her with Yitrium 90 a couple times, and then switched to bland embolization just to keep these tumors suppressed. There's still a little bit of tumor, but it's been suppressed, and it's been five years now since I did this initial treatment, and she's still doing very well. So this is an example of a very good response. Okay. Perioperative and post-operative management. I'll just talk about this briefly. I do like to give Sandostatin whenever we're doing these treatments, even in patients that don't have a diagnosis of hormone-secreting tumors. And the reason is that when you're burning the tumors or you're depriving them of oxygen and causing them to become ischemic, they can secrete hormone, and that can cause symptoms of carcinoid, carcinoid syndrome. And I just like to have some prophylactic octreotide on board to minimize the likelihood of that being a problem. One other thing I'd like to mention is with all of these treatments, that you have to be careful about imaging afterwards and assuming too much in terms of if you get a CT scan, say 2 weeks or a month after an ablation or an embolization, the tissue around the area may swell up as a result of the inflammation, the localized inflammation from either the tumor, from the tumors dying, and the CT scan may look like the tumors are bigger, and sometimes the radiologist, not knowing the history, may put in their report that there's progression of liver disease, just when really what they're seeing is the inflammatory after effects of a recent treatment. So you have to wait about 2 or 3 months to really let the inflammation subside and get a good sense for what you're dealing with after treatment. So for both the doctors out there and the patients, if you have a CT scan or an MRI of the liver within a few weeks or a month or so after any one of these treatments, don't be alarmed if the report says that that the tumors look a little bit bigger, because that could just be due to inflammatory after effects of the treatment. Okay, I think that's about it. So I think we're not taking questions now, but appreciate your time, and thank you very much for listening to me. I'll hand this over to Dr. Sharma again.
Thank you, Dr. Itagaki. What a great presentation, very thorough and informative. I think we're now open for question and answer session.
So if all the doctors can turn on their cameras, that would be great. And Paul and Gary.
All right, I'm still here. Thank you to all the doctors who made these presentations. It was really interesting. Amazing too that we're really on time and even a little ahead of schedule. And we have some questions here. Let me bring these up. Actually, I'd like to just ask one question. It seems like it always comes up. Is you had some really interesting presentations. Are these at all available? Are your PowerPoints available? I think maybe discuss that with Dr. Sharma, and then if they are, send them over to Gary, and Gary would put them up on our website, our support group's website. Okay, so you can
also, this recording is available on your website, and as well as Nortel Carcinet's Facebook page. So the recording is live and will be available, so you'll be able to see the presentations there.
Great, thank you.
Okay, thanks. And let's see, there were some questions which actually already were answered through the chat. And hopefully everybody, there's a little chat button. Hopefully you can find the chat button at the bottom of your page and click on it, and you'll see these questions as they come through, as well as I can read them off. So one question here is about the directed PRRT to the liver. is there, I don't remember much of a discussion about directed PRRT to the liver. Any comments about that? Are you seeing some experience with that, Dr. Sharma?
Yes, and I think Dr. Mehta probably has more insight into this.
Mostly that it's in phase 1 clinical trials as an experiment, so it would be, the idea would be to try to duplicate the Y90 experience in the liver with an intra-arterial injection of this agent, so that you're actually using a targeted agent.
Okay.
No published experience yet.
Yeah, this is still phase 1 trial, so it's ways off yet, at least in the US. Okay. And this is a question that I know often comes up related to something like especially embolization and PRT. Is there some knowledge then, if you've already had some form of embolization, and blocking of the arteries that feed these tumors, then does that preclude being a candidate for PRRT in the future? Does one exclude the other? Any comments about that experience?
Yeah, I can chime in on that. Somebody asked in the chat about whether bland embolization would potentially have an impact on your ability to get PRRT, and I think the answer to that is no. Remember, PRRT is a systemic therapy, so if you have diffuse mets all throughout the body, you can get PRRT. And the liver-directed therapies like bland embolization and even Yitrium 90 radioembolization are targeted only to the liver. Now, if somebody was to have, say, maybe 2 or more sessions of Yitrium 90 radioembolization to the liver, and then they still had which is pretty much the max of what we can do before we start to endanger the liver, the normal liver itself, with radiation injury. And then they were to potentially think about doing PRT. The radiation oncologist or whoever's working with them on the PRT would have to consider the additional liver dose that would come from the systemic PRT therapy, and make sure that it just wasn't too much to tip the liver over the edge. So prior radiation exposure to the liver, I think, would be a consideration. Maybe Dr. Mehta can comment on that.
No, I think you answered it quite well. And I think a lot of these things get to be case by case when you get further and further out on the branches, so, but usually they don't preclude each other.
All right, thanks.
Yeah, and I think that's where the sequencing of treatments also play a role. If somebody has a lot of, liver burden of the disease, and not, the extrahepatic disease is low, Y90 is an excellent alternative. Also for tumors which are not positive for somatostatin analogs, Y90 is a great treatment for liver-directed therapy. For patients who have larger burden of disease, extrahepatic larger burden of disease, I think bland embolization up front, so that we can have options for PRRT down the lane, would be ideal.
I guess along the same line of discussion about the embolization, probably Dr. Itagaki, what about let's say particle migration? The embolization, does it go beyond your target? Is that much of a problem, or not a concern?
Yeah, no, it is a concern, but it is in the case of liver, a neuroendocrine tumor, not usually much of a problem. So when we are doing radioembolization with Yitrium 90 or TARE, we, as part of the safety protocol, we do a check to see if when you inject radiation into the liver, if particles leak out, and then the next stop would be to the lungs. And so we calculate what's called a liver shunt fraction. So, if you're injecting 100 particles into the liver, how many of those particles actually stay in the liver? Certain kinds of tumors, not neuroendocrine, usually things like hepatocellular carcinoma, they can be very leaky. And so particles injected can pass through and go directly to the lungs. And so we want to make sure that that we check for that using a technetium scan. Technetium is used in a lot of nuclear medicine scans. It's an inert kind of radioactive imaging agent that does that safety check. So it is a concern enough for us to do the check. And if there is a lot of leakage through the liver, then we may have to dial down our dose because we don't want a lot of radiation to go where it shouldn't, for example, to the lungs. But that is usually not an issue with neuroendocrine tumor. Hepatocellular carcinoma, which is another kind of cancer that we do Yttrium-90 treatments for, is the one that typically has that problem. So we'll do the check, but I've not personally had any patients that have failed to be eligible for Yttrium-90 treatment to the liver because of that with neuroendocrine liver mets.
Okay, thanks. Let's see, how about a question about the Nanoknife? Question about can the Nanoknife be used on liver mets or just on a specific organ like the pancreas? Dr. Ong?
Yeah, so it's approved for any soft tissue. The limitation on the Nanoknife is literally about size. So in the liver, it can be used for, and has been used for areas that are critical, such as like by the bifurcation of the bile ducts. Again, the difficulty is that usually if a patient has liver metastasis, it's very unlikely that a patient will have a solitary small metastasis at a single site in a critical spot. It just isn't very common. So while it can be used in the liver, where I've seen it be used sometimes is in combination with other liver-directed therapies, microwave or radiofrequency ablation, as an adjunct. So for example, you don't want to cause thermal injury to something within the bifurcation, and you decide to apply the Nanoknife. Those are very limited cases, and it's usually done in combination with your interventional radiologist as well as the surgeon to try to do planning. Those critical areas are usually done in the operating room only because you want, and not that it can't be done by interventional radiologists, but there's a lot of times that there are other things that may be going on that are required. For example, biliary strictures that need to be reconstructed. So to kind of expound upon what the specific question, the real limitation is that Nanoknife can only be used up to about a diameter of 2 centimeters. So again, it's very highly specialized in terms of its utilization.
Okay, thanks. Let's see. We have a question about just a general question about metastatic breast cancer. I guess it's about mets to the liver. What are the best treatments for that? Does the source matter, or once you have the liver mets, any of the typical techniques to ablate those or treat those would be the same?
Yeah, I think, of course, we can use the endocrine therapies, the estrogen blocking agents for the breast cancer if they have receptors positive for them, and they will be systemic therapies and work everywhere. However, they can safely be used in combination with the liver-directed therapies. I think Dr. Itagaki alluded to the patient who he showed in his presentation had breast primary and had a great response to the liver-directed therapies in the liver.
Okay. That brings up a question. We talked about these all the clinical trials, and they always talk about progression-free time. What progression are we talking about? Are we always talking about because the study may be for, let's say, pancreatic NETs. Are we talking about progression of a lesion in the pancreas, or are we talking about METs that have occurred to the liver already? And then we're looking at, when we talk about progression-free survival, we're talking about the METs in the liver. Is it the primary or the METs or both, or what?
So in the studies, progression is defined early on, and typically any progression of more than, 10 to 15% of the primary disease side, or a new lesion or metastatic disease. So if the net disease is increased, more than 10 to 15%, and if there are new lesions, that is defined as progression.
So new lesions anywhere, basically.
Right.
I see. Okay, a couple of questions here have come up about the copper 64 scan. Are you seeing that actually being approved and done anywhere right here around Seattle, or what's your knowledge of the status of that scan?
I haven't used it here in our area, but there are others. Dr. Itagaki, do you have any insight into that? We are not using it in Swedish yet.
No, I've not seen it at any of the facilities that I work at. It may be as part of research protocol available at academic medical centers, but I can't speak.
It's actually it's FDA approved.
It's approved, yeah. Yeah, so it's approved, I think, because we are at a lot of major institutes, because you're making your own gallium, so you don't really, maybe there's a switch, but I don't think we have been approached about switching to copper at this point. To my knowledge, they're kind of equally effective in their sensitivity, both gallium and copper, so they can be used alternately. Yeah, maybe Josh, you have some other insights.
Yeah, it's approved. It's actually more widely available because it's distributed because of its long half-life. You can send it to more places. So any place that can order from radiopharmaceutical distributions can certainly get it. The bigger issue is that you actually get repayment for it. Medicare, you haven't actually gotten any repayment for your gallium-68 net spot for over a year now, and copper 64 has reimbursement for Medicare. So you may be interested in that, since that's how you guys get paid.
Yeah.
So where I've seen this being used is actually in places like Alaska, because it's harder to get the agent to do a net spot study there. And it's
actually used in San Francisco Bay Area. Both UCSF and Stanford use it for also patient scheduling, because you can get it overnight. It's produced in mass batches, so it's actually easier or faster to get it as well, although they're using both of them. So it's being used in more places also for scheduling, because there's not as much as a schedule wait or competition for the 3 elutions that are coming off of a net spot off of a gallium-68 generator.
So the bottom line is it's really come down to more of an availability and convenience of producing the isotope versus a better resolution or better results. Is that what we're really finding?
I'll chime in here, because I work a lot in this area, but you're also, if my camera does show up, you're also finding that, and certainly Dr. Hope was on a conversation with me about 2 weeks ago. There's some challenges with noise in the copper 64 versus gallium 68. So there are some challenges with using it and getting used to using it, and I've heard this from Stanford as well. So it is, there's an availability part, there's also a reimbursement part, but there's also some more things to learn to tamp down the noise from the scan itself. So, you know, it's a work in progress, but honestly, centers that have used NetSpot haven't gotten paid for Medicare patients for the tracer since January 1 of 2020. And that's about a $3,200 hit every time a patient takes one, that your centers aren't getting paid. So there's work right now in the SNMMI to try to alleviate this and stop this weird, strange pass-through after 3 years, or the stopping of pass-through. But it's a work in progress. And right now, Copper 64 has been reimbursed since the beginning of the year for those who are on Medicare. So there's a lot of mixed things going on at the moment.
Okay, thanks, Josh. Okay, I'll read off here a question regarding small intestine non-surgical primary. Is there a way to get into the small intestine or to remove the primary using robotics, or any comments on how that inoperable primary could be excised, I guess, or treated?
So let me understand the question. The question is that the patient has a non-primary or a primary small bowel neuroendocrine tumor?
A primary, and it's non-surgical, is what she says. It's in other words, can't be surgically removed.
Yeah.
Another way to get to it.
Yeah, so I think that what that person is speaking about, because it's hard for me to imagine a small bowel primary in the small intestine itself that can't be removed. It's more likely that there is progression of disease within the root of the mesentery, which is very common amongst small bowel neuroendocrine tumors. And you know, unfortunately, robotics is just a way for us to do surgery with small holes. So it has to do with the way we approach the abdominal cavity. What makes these neuroendocrine tumors unresectable when they're involved from the small bowel is typically the location of the metastatic lesion, meaning that there's lymph nodes involved and they're surrounding a critical blood vessel that makes them, quote, unresectable. There are people that have used strategies like Nanoknife. So it's not really the robotics, but it's maybe other adjunct treatment plans that are used to try to either debulk the amount of disease, but understanding that there are risks associated with the blood vessels. So clearly we don't want to injure the remainder of the bowel, because that would create a very, very poor quality of life. But there are people doing selective lymph node resections with a technique called I don't know if you guys are all aware of this one, but the Chinese dumpling technique that was from Louisiana. There's a surgeon or a person that's doing localized chemotherapy into the mesentery after a lymph node resection. We've done that at Swedish. It's another tool that we've done to try to reduce the local recurrence within the root of the mesentery. But that's probably what makes the small bowel neuroendocrine tumor non-resectable, not the site of the small intestine. Almost anything in the small intestine can be removed.